Okay. So without further ado, I'd like to introduce our first speaker, who is coming to us from India. Uh, thanks to Rihanna, who's put us in contact. So here we have Dr. Roshni Changalath, who is a consultant obstetrician and gynecologist, has a string of letters behind her name, which I think is just a small part of her very interesting work experience and career, which we're excited to hear about. And she'll be giving us a talk on her humanitarian experience with MSF. Please feel free to take the floor.
Thank you so much, Maddie. Am I audible?
Yeah, we can hear you.
Thank you. Good evening, everyone, and thank you for having me here today. So as Maddie introduced, my name is Dr. Roshni Changalat, and I have been a practicing obstetrician and gynecologist over the last 10 years. And I also have experience working in resource-limited settings, not only in India, but also in humanitarian contexts with MSF. So I think I had to share my screen. Yeah, just give me a minute. Is this visible? Okay.
Yeah,
Yeah, better?
that's perfect. Do you want to just check you can move the slides?
Yeah,
And then yeah,
it's good. Yeah.
everything.
Okay,
Great.
fine. Thank you. So I think I'll start with the topic. Today I'll be presenting on emergency obstetrics in fragile systems, and I will be speaking from my experience in Afghanistan. So in today's talk, we will be examining maternal mortality to the 3 delays model, understand how a health system breakdown contributes to preventable deaths, and also go through 2 clinical case scenarios. So the goal today is not only to understand what happens clinically, but also to understand where systems fail and what interventions actually save lives. I hope you're able to follow me, and if I speak too fast, you can just let me know. So coming to the context of MSF in Afghanistan, I would like to give a small introduction. MSF has been working in Afghanistan for over 4 decades, supporting an extremely fragile and under-resourced healthcare system, especially in regards to maternal and child health. In 2024 alone, MSF has been supporting multiple hospitals across 8 provinces, as you can see in this map. And these facilities function as referral centers, often serving populations with very limited access to comprehensive emergency obstetric care. And this picture down below here, the Bose Provincial Hospital, is where I was working, which is located in Lashkar Gah, which is in the southern district of Afghanistan. So Afghanistan, if you look at the prevalence of maternal mortality, over the last 2 decades, it has reduced by around 51%. But if you look at WHO standards, they aim for achieving a maternal mortality of less than 70 per 100,000 live births by 2030. If you compare to that standard, Afghanistan currently faces one of the highest maternal mortality ratios in the world, estimated to be now around 638 per 100,000 live births. Multiple factors ranging from war and poverty to illiteracy, lack of infrastructure contribute to the high MMR in Afghanistan. Moreover, following the Taliban takeover, international donors have withdrawn funding, and also now the estimate stands at this could rise further if systems disruption continue. So what makes the situation particularly concerning is that most of these maternal deaths are preventable with timely interventions. So that brings us to the 3 delays model. And now we use this, which remains one of the most powerful frameworks in global obstetrics, to understand the maternal mortality rates in different contexts. So coming to the delay 1, which is delay in deciding to seek care. Now what leads to this is lack of awareness of danger signs, financial barriers, or lack of decision-making autonomy. Delay 2 is the delay in reaching a facility. That could be due to problems in transport, infrastructure, facilities, lack of ambulances, and the general insecurity of that geographical location. And delay 3 is delay in receiving appropriate care once a patient has reached a facility. And again, this includes shortages in trained staff, lack of medications, delay in diagnosis, or generally system inefficiencies. So, to reduce maternal mortality, healthcare systems globally have been relying on functioning emergency obstetric care networks. So, we have the basic emergency obstetric and neonatal care and the comprehensive. So, when it comes to the basic, it includes essential functions such as administration of antibiotics, uterotonics like oxytocin, misoprostol, and anticonvulsants like magnesium sulfate, performing assisted vaginal delivery, neonatal resuscitation, and manual removal of placenta and removal of retained products. These are the basic facilities that is expected to be provided in a basic obstetric care. And then we have the comprehensive care, which includes the previously told, along with the capacity to have cesarean sections and also a blood bank. But in fragile settings, what we mostly see is the main challenges, which includes staff shortages, supply gaps, unreliable electricity, and lack of blood availability. So even when facilities exist physically, they may not function effectively. And that functional gap is where many maternal deaths occur. To give you a context, in some MSF-supported maternity hospitals, the delivery volumes averaged between 70 to 100 births per day. So that comes to approximately on an average of 25,000 to 36,000 deliveries per year in a single facility, when a safe capacity is supposed to be around approximately 9,000 to 10,000 deliveries. So this level of workload places enormous strain on staffing, supplies, and the capacity for emergency response. So what is important to understand is that maternal deaths rarely result from one delay. They usually result from a cumulative effect of all three. So with that, I will go on to our first case study, which is a case of severe preeclampsia, which was a near-miss maternal event. So this was a young woman at 36 weeks of gestation who presented with severe hypertension and history of convulsions and a proteinuria of 3+. So she had symptoms of severe headache and visual disturbances, which are classic warning signs of preeclampsia. However, she was not having any antenatal care till date, and this represents the first delay. That is, the danger signs were not recognized early. And she arrived after a significant delay due to transport barriers and social constraints. In Afghanistan, for a woman to step out of the house, she needs to have what we call a mahram, which is a male companion. It can be a partner, a relative, has to be with the female for her to access even basic facilities or even healthcare. So at the primary health facilities, there were additional challenges also, including delay in diagnosis and lack of immediate access to magnesium sulfate, which represents the third delay. So finally, she was referred to our facility, and by that time, her blood pressure had further increased to 170 over 150, placing her at an extremely high risk of ICH, intracranial hemorrhage, and further seizures. So in any pregnant patient presenting with seizures, eclampsia must be assumed until proven otherwise. So when reaching our facility, immediate emergency management was initiated. Following the ABC approach, airway was protected, oxygenation was started with high flow oxygen and IV access with 2 widebore IV cannulas, ideally 14 or 16 gauge. And the most important life-saving intervention is magnesium sulfate, which is administered both as a loading dose and as a maintenance dose for seizure prophylaxis. So magnesium sulfate reduces recurrent seizures and maternal mortality by at least 50% and is considered the gold standard for treatment worldwide. So for anyone who's interested in how magnesium sulfate is given, I have just given a flowchart here. So ideally in low resource settings, we will not be having a magnesium sulfate IV infusion pump. So we usually give it as IM regimen, which is we give a loading dose of 4 gram IV stat and followed by 5 gram in alternating buttocks every 4 hours. And this continues for 24 hours. Either you calculate from the last seizure or from when she had a cesarean birth or a delivery. So then what happens is when you are giving magnesium sulfate, you have to be also closely monitoring the patient to detect magnesium toxicity. Again, there will not be any lab facility. Only we have lab facilities, but only for basic investigations. So we are not able to do serum magnesium levels to look for toxicity levels. So we have to depend on clinical signs. Here, the clinical signs being if her respiratory rate has gone below 12 breaths per minute, if she is having decreased urine output of less than 25 to 30 ml per hour, or if her deep tendon reflexes, such as the patellar reflex, is absent, or if she has severe hypotension. So in such a situation, you have to stop the magnesium sulfate immediately, and then you have to give her the antidote, which is calcium gluconate. Apart from magnesium sulfate also, it is really important to also control the hypertension to reduce the risk of intracranial hemorrhage. And reach the target systolic BP should be around 140 to 150, and the diastolic should be around 90. So for this, we have the options of IV labetalol or hydralazine. And if it's orally, we have to give nifedipine if IV is unavailable or IV access has not been taken. So definitive management is delivery, but maternal stabilization always takes priority before delivery is attempted. So following stabilization, she subsequently delivered vaginally. And the mother survived without further seizures, and even the baby was fine. So this case represents a near miss and illustrates how timely intervention, even when delayed, can prevent maternal death. And coming to our second case study, this represents a preventable maternal death due to postpartum hemorrhage. So the patient was a multiparous woman who delivered at home and developed heavy bleeding due to retained placenta. So decision to seek care was delayed due to financial and access barriers, which is kind of similar story for most of the women in Afghanistan. At the primary care facility, further delays occurred due to inconsistent uterotonic use, lack of transfusion availability, and limited emergency response capacity. So by the time she reached our facility, she was already in hypovolemic shock. Clinically, she had tachycardia, hypotension, altered consciousness, and signs of poor peripheral perfusion, indicating decompensated hemorrhagic shock. So emergency management was initiated, including IV fluid resuscitation and preparation for blood transfusion. However, there were delays in availability of blood products, and definitive hemorrhage control was delayed. Despite resuscitative efforts, she suffered cardiovascular collapse and could not be revived. Now, this is a classic example of cumulative delays leading to a preventable maternal death, because postpartum hemorrhage is highly treatable, but only if interventions are timely. Ideally, after a patient delivers, we all have to follow the active management of third stage of labor. Despite this, if the patient still continues to bleed, ideally we call it a minor or a major PPH once she has crossed a threshold of more than 500 to 1 liter of blood loss. And you should also keep in mind, most of the women in these contexts are already anemic, and they have not had any antenatal checkup till now. So they are not on any iron supplementing drugs or even nutritious food or anything of that sort. So on an underlying situation of anemia, when a patient even loses just 500 ml of blood, she will be classified as a PPH. And we have to be alert and we have to respond in as an emergent situation. So ideally what happens is, once a PPH is recognized, the management must begin immediately and simultaneously on multiple fronts. The first step is activation of the emergency response team and rapid clinical assessment, again using the ABC approach. So once we assess the airway and breathing, oxygen is administered, and again circulation is maintained by opening two IV cannulas with two large bore IV cannulas, again 14 or 16 gauge, and rapid crystalloid infusion while we wait for blood products. At the same time, the cause of bleeding must be addressed. So uterotonics such as oxytocin is the first line of therapy. And along with this, we can also give misoprostol. I have again given a table with the dosage and how frequently we can be giving it. And tranexamic acid is one wonder drug, which you give a dose of 1 gram IV, should be administered as early as possible and within 3 hours of birth, ideally. And now this reduces mortality by preventing fibrinolysis. At the same time, continuous reassessment is essential to make sure if she is stable or if she is worsening. If bleeding persists, secondary causes must be evaluated. The 4 T's: tone, tissue, trauma, thrombin. These are the 4 T's that you should remember. And most commonly, it is always due to uterine atonicity. But if not, you have to look for other causes. And if uterine atonicity persists, despite medical therapy, that is when we move on to the mechanical methods, such as most commonly what we use in these contexts is a uterine balloon tamponade. I can just show you a picture here. This is a uterine balloon tamponade. What we have is a Bakri balloon, which is inserted inside the uterus. It has to be inserted incorrectly. This is an incorrect placement. It is where it stops at the cervix. It has to go up to the fundus of the uterus. And ideally, it is inflated to around 250 to 500 ml, depending on how the bleeding stops. And other measures are, apart from that, what you see here is a non-pneumatic anti-shock garment. And this is something that you don't have it inside the labor rooms per se, but we use this when we are transporting patients from any primary health facility to a tertiary facility. And this also helps to prevent bleeding. And these are other methods with which we can also, in the labor room during the emergency, bimanual compression of the uterus, where one person is compressing the uterus both intravaginally and per abdominally. And also aortic compression, where we apply sufficient pressure on the abdominal aorta until the femoral pulse is no longer felt. So following these mechanical methods and still she continues to bleed or hemodynamically compromised is when we move on to the surgical methods. She's immediately rushed to the OT and examined under anesthesia to see if there are any tears, a cervical tear or a vaginal tear or a paravaginal tear. If anything has been recognized, it has to be repaired immediately. There is no tear and she still continues to bleed, or if the uterus is still atonic, then we apply brace sutures such as the Belin sutures, and we do a stepwise devascularization and internal iliac artery ligation through a laparotomy. If none of these techniques are successful, finally it does end up in a hysterectomy or a partial hysterectomy. So the key determinant of survival is not the availability of advanced interventions, but the speed of recognition and initiation of these basic life-saving measures. In many fatal cases, death occurs not because the treatment is not known, but because it has been delayed. Now, addressing these 3 delays, to reduce maternal mortality, interventions must target all 3 delays simultaneously. At the community level, education and empowerment improve early recognition and care seeking. At the transport level, ambulance networks and referral coordination reduce delays in reaching care. At the facility level, ensuring availability of medications, trained staff, blood, and standard protocols improves the chances of survival. So no single intervention alone is sufficient. System strengthening must be comprehensive. Easier said than done, because in Afghanistan, what we noticed was because of the high insecurity context, we were only able to focus on the 3rd delay, which is strengthening our facilities, because we are not allowed to. There have been a lot of opportunities where we tried to go to nearby primary health facilities and train the midwives or train the staff, but with more and more restrictions being put in place as of the last 3-4 years, it's becoming even more difficult for us to do any kind of outreach. So the only thing we can depend is when a patient or her extended family visit the facility, we try to hold them at that time and give them whatever counseling we can, whatever awareness we can, so that they can pass on the message. So in Afghanistan today faces a maternal health crisis that is as much political as it is medical. Because currently, as of even last week, the news has come out from Taliban that they have banned girls from going to school. And in 2024, they had banned nursing and midwifery schools. And female health workers are restricted in their ability to work. And the results are tragically predictable. When all these things are put together, women give birth without skilled support, and preventable maternal deaths are on the rise. Hemorrhage, eclampsia, sepsis, and obstructed labor. These are the leading killers of mothers in low resource settings. And in Afghanistan, where cultural norms already restrict women from being treated by male doctors, shutting down female education and employment in healthcare is a decision which is going to have fatal consequences. So the key interventions needed are pretty straightforward, but they require system commitment. Protect maternal healthcare funding, ensure reliable supply chains of essential medications, strengthen referral systems, train and support healthcare workers, implement standardized emergency protocols. Because ultimately, maternal survival depends on the basic principles: early recognition, rapid stabilization, and timely definitive care. Even in fragile settings, consistent application of these fundamental basics saves lives. Maternal deaths are not inevitable, they are indicators of system failure. And that means that they are preventable. Thank you. And these are the amazing doctors and midwives that I got to work with in Lashkargah. Really strong, bold, resilient women who are so passionate
Oh,
about their work and saving every woman in Afghanistan if they can. Thank you.
sorry if I jumped in. Our internet cut out for a moment there. But thank you so much for that, like really fascinating and engaging talk. I'm sure that's like a tiniest part of your enormous experience out in Afghanistan.
It's
Um,
a bit overwhelming also. So
yeah, that a handful of cases definitely don't begin to encompass the
yeah.
level of barriers that I'm sure you've witnessed firsthand. I if anyone has any burning questions, that would be great. We'll welcome the floor is open. I've got a couple in case no one's immediately forthcoming, but I'm sure there are many.
I think in Afghanistan, it's like you keep feeling like, because I went in 2024 and even gynecologists who have come even 10 years before me have been giving the same reports.
Yeah.
And you expect that, they have given solutions, at least from the facility level, what we can do. But what I've noticed is because of the so much instability happening externally,
Mm,
everyone is trying to do their best, but we are just going around in circles. And things don't seem to have changed much. And now, with even more restrictions being imposed on all the women in the country, it's something that is even more, it's difficult to even imagine to what context it's going to affect not only mothers but women in general.
mm. I mean, so frustrating
It is.
for
It
healthcare
it is
workers.
very.
Yeah. I was going to ask what proportion of mothers or to be mothers are receiving any, uh, not even to consider the kind of WHO minimum basic antenatal care in your experience.
I think it will be around just 15 to 20%.
Right.
I
Who
mean,
will have
in
seen any.
Lashkargah, we were catering to around, I think, averaging 3 million population. And this includes both men and women. And but even then, for the antenatal clinics, it has not decreased per se, especially after the 2021, even the Taliban takeover. The security wise, at least some situations had, the borders had started opening up. People were able to travel from one district to the other. So we were seeing a small rise, but now not so much again because the restrictions have again become worse in the last 2 years.
Heartbreaking. Um, Dan has asked quite a logistical question in the chat saying, is there any time limitation for giving TXA? Like, have you
No, there's
reached a
no
point where
time
it's no longer
limitation.
beneficial?
Ideally, yes, it is most effective if we give it immediately in the 1 to 3 hours post delivery. But once that is because why it's to prevent fibrinolysis, it's before the DIC starts setting in. But once the hemorrhage has gone to a level that the patient is hemodynamically unstable, we can give it as a maintenance dose, but the immediate action is not going to be as high as it is when you give it immediately, because it does take some time for the DIC to set in, ideally, if especially if you're already giving her crystalloids and starting her on transfusion. So
Mm.
immediately it should be within, ideally within the 3 hours. But we still
Mm.
do give it in some contexts, like obviously in Afghanistan also. And even in our practice, we do give it for the first 24 hours to 48 hours. But beyond that, it's not of any use.
And so kind of within the first day to two, there's still some benefit, we believe.
And like ideally, price dosage, TID dosage is what is ideal.
Okay, thank you so much. Um, well, if no one else has any immediate questions, I know it's really late with you, Roshni, so I'm sure
Yeah, that's okay.
we really appreciate your time.
Thank you so much.
So any further questions, I'm sure you can direct them directly to Roshni or through the chat or through me
I can
if
also, I'll just put in my email ID. If anyone has any further questions, you can just get in touch with me through mail.
yeah, I mean many on your work in general, but I don't know if all of them would be suitable for this audience.
No, that's totally fine. I mean, if you feel you have the time, you can ask me anything. That's totally fine.
Okay.
It doesn't have to be
I
only in this context.
I think for the purpose of the Grand Round, we should probably move on to Joy's presentation, but I'll be in contact. Thank you.
Sure. Thank you so much. Thank you. Thank you, everyone.
Okay. So what you saw at the start was the our spotlight on, which has kindly been provided by Ash for this month. Let's see if I can find that again to share while Joy just gets herself ready. Um, our spotlight on is a poster that can be on any kind of global health topic, and we welcome anyone who's keen to write or anyone who has something that they would like us to present a poster on. It normally goes on display in our BRI ED rooms for the next couple of months. So just checking in with Joy. And how did I do this? There we go. Joy is going to be our next speaker, and she is a registered nurse in Laikipia County, who works in a rural health facility nearby, and she's going to have a chat with us about her experience and how she and her management in her setting of obstetric emergencies. Um, if you are there, Joy, please take the floor. She was having some connection problems earlier, so that might be why there may be a little bit of a delay. Um, Joy, how are you doing? Um, oh,
Hello. Good evening, everyone.
hi,
Okay, my
Joy.
name is Joy. Good evening.
Yeah,
Good
we can hear
evening,
you well.
Mandy. Can you hear me well? Okay. My name is Joy.
Oh, I didn't. Have I accidentally muted her? I'm really sorry. I think I've accidentally muted you. or this might be internet. No, hello. Sorry, we can't actually hear you, Joy. Just muted.
Hello.
Oh, you're back. Okay. Would you like me to share your presentation?
Yes, yes.
Wonderful. Okay. Here we go. Share here. Share screen. Lovely. Can everyone see that? More importantly, can Joy see that?
Hope it's
Yeah. Is it moving?
okay. Okay.
Great.
So tonight I'm going to share with you people some of the most common obstetric emergencies and how we really handle them in our rural settings. So I'll majorly based on how we handle them in our rural settings. And so we are going to begin with the most common ones. I'll be tackling postpartum hemorrhage, preeclampsia, eclampsia, obstructed labor, and maternal sepsis. And our objectives tonight will be, number one, identify common obstetric emergencies, and number two, outline immediate management in rural settings. Three will be understanding the referral principles, and number four, how to improve maternal outcome through preparedness. Okay, we begin with postpartum hemorrhage. What is the definition of postpartum hemorrhage? Postpartum hemorrhage is defined as any mother who has got blood loss of more than 500 ml, that is in vaginal delivery, or more than 1,000 ml, that is for CS, or that have not documented here, but it is also relevant. Maybe a mother could be having an HB of 7, and this mother loses like 200 ml of blood. This will be significant to the life of this mother, and it will be life-threatening. So that can also be taken as a postpartum hemorrhage. Next. What are the causes of postpartum hemorrhage? The causes of postpartum hemorrhage, we call them the 4 T's. Number one is tone. What is tone? It is the uterine atony. The uterus after delivery fails to contract, which leads to postpartum hemorrhage. Number two, it is tissue. What do we mean by the term tissue? These are retained product of conception. Maybe after delivery, the membranes are retained in the uterus. That will cause postpartum hemorrhage. And number three, it is trauma. What does this mean? Trauma, that is tears to the cervix, tears to the vaginal wall, or tears to the perineum. And number four, it is thrombin, the clotting factor. The blood fails to clot, which leads to PPH. Next. Next, PPH management in rural settings. This is typically how we do it in our settings. The ideal how we do it in our rural settings now, before we go for the referral. Number one, what you should do is call for help. For PPH, you really can't manage alone. You need help, so you have to call for help. Then you assess for the ABC, the airway. You make sure that your mother is breathing, the circulation is okay. Then you access 2 large cannulas so that you may start your IV fluids. And the preferred IV fluids that are accessible in our settings, it is the normosaline and the Ringer's lactate. Those are the fluids that we normally have in our rural settings. And how do we give these IV fluids? We give them at a rate of 1 to 2 liters within the first 1 hour, so as to make sure the mother is safe. Then you keep on monitoring the vitals, especially the BPs and the breathing of the mother, so that you make sure the mother doesn't go into hypovolumic shock. Then you do the uterine massage. That is, you massage the uterus to make it contract, so that you prevent the PPH. Then you make sure the bladder is empty. Then you give uterotonics. The uterotonics that we have here in our rural settings in Kenya, we have the oxytocin, which we give as IM, 10 international units, or the IV, which we give as low in the IV fluids. And in cases where we don't have oxytocin, we give them misoprostol orally. Then within the first 3 hours, you can still give tranexamic acid. Then you examine for tears and repairs. This ideally what we do here is we assess the 4 T's. You examine for the tears and repair if any. And if any retained products of conceptions, you expel them manually. If still you cannot stabilize the mother, you have to refer urgently to a facility where further management will be done. That is the blood transfusion. There is a theater to do maybe the hysterectomy, to do the uterine tamponade, all that where it can be done. Next slide. Next. Prevention of PPH. How do we prevent PPH? It is by active management of that stage, not her still, but arm still. Active management of that stage. What are the components of arm still? Number 1, immediately after delivery of the baby and after you confirm that there is no second twin, you administer the uterotonics, that is the oxytocin. Then, how do we deliver our placenta? By controlled contraction. And how will you deliver it after ensuring that there is placental separation? What are the signs of placental separation? Number 1, the cord will elongate, then there will be gushing of the blood. By that, you will apply controlled contraction. That is, you apply pressure on the uterus with one arm, and the other arm pulls out the cord to get out the placenta. Then the number 3 component of arm still is uterine massage and delivery.
Question.
Next. Next. Okay, the second topic is on severe preeclampsia. What is the definition of severe preeclampsia? Preeclampsia with severe features occurring at 20 weeks gestation in a previously normotensive woman. What is preeclampsia? Preeclampsia is when the BPs start going higher, above 140/90. But now the severe preeclampsia is the severe form of the preeclampsia, and it must be above 20 weeks gestation in a woman who was previously normotensive. This woman had normal BPs previously, but now she presents with the severe form of the preeclampsia. What is the diagnosis? The blood pressures must be above 160 over 100 millimeters of mercury, and a proteinuria of above 3, plus headache, visual disturbances, epigastric pain, origuria, that is urine below 500 ml per 24 hours. Then there is low platelet count, which is below 1,000 or 100,000. Then there will be elevated liver enzymes. Those are the signs that will tell you that this mother is developing severe preeclampsia. Next. Eclampsia. What is the definition of eclampsia? New onset generalized tonic-clonic seizure in a woman with preeclampsia. This woman had preeclampsia, the signs that we've talked about in the previous slide. But in addition to this woman presents with a seizure. So when this woman presents with a seizure, it's no longer preeclampsia, but it is now eclampsia. So that is the definition of the eclampsia. Signs and symptoms are like for preeclampsia, like I've said, plus now a conversion. Next slide on management. Yes, on management, in our rural settings, so what we do, you call for help, then ABC of importance, support this woman with oxygen, Then stop seizure. What do you stop the seizures with? With magnesium sulfate. You start with a loading dose of 4 grams IM, then 10 grams, 4 grams IV, then 10 grams IM, 5 grams in heat buttock. Then you control the blood pressures with either nifedipine or hydralazine, and then you do immediate referral of this mother, because if you continue keeping the mother with high blood pressures, this woman might have organ failure. Next. Next. Magnesium sulfate administration, like I was saying, the loading dose of 4 grams IV, slow, plus 10 grams, not milligrams, 10 grams IM, that is 5 grams in heat glutea, then maintenance dose of 5 grams IM for hourly. Key points to note, and what we usually do in our rural settings to make sure we are ready for preeclampsia, eclampsia, we always keep magnesium sulfate and nifedipine in our emergency trays in our maternities. Then we encourage our mothers to come for ANC visits so that we keep the BP visit. Then in case of BP, we don't wait for these mothers to come to deliver in our facilities, but we refer them earlier to facilities where they will get better management other than coming to rush with the referrals. Next. Next slide. Okay, the next slide is obstructed labor. And what is obstructed labor? It is failure or of descent of the presenting part during active labor due to mechanical obstruction. This could be maybe due to fetal macrosomia, the baby is big, or could be due to cephalopelvic disproportion. That is, the pelvis is too small for the passenger. That is, the passage is small for the passenger. Then there is the malpresentation or malpositions. Then there is the fetal causes is the fetal macrosomia. The pelvic causes is the CPD. Next. The management is you assess for ABC, airway, breathing, and circulation. You access IV, then you refer urgently. For obstructed labor, there is nothing. We don't even try even the maneuvers, even in shoulder presentation. We just refer mothers to a facility where there is a theater where they can be operated. For prevention, it is proper ANC follow-up with routine ultrasound scans so that you can know the position of the baby, the lie, and the presentations. Then there is labor monitoring. When a mother comes in after admission, we make sure you monitor the mother using a pathograph, because it will tell you when you go out of the normal labor. Then you early diagnosis and referral. You must be vigilant in diagnosis so that you may make early referral to save the life of the baby and also to save the life of the mother. Next slide. Next. Okay, we have maternal sepsis. This is a life-threatening condition, which is defined as organ dysfunction resulting from infection during either pregnancy, childbirth, postpartum, or post-aborto. All those conditions that lead to organ dysfunction during those periods, they are what we refer to as maternal sepsis. And what are the most common causes of maternal sepsis? Number one, in postpartum, there is what we call retained products of conception. When the products of conception get retained into the uterus, they cause infection into the uterus. Then there is also abortion, the septic abortions, which also lead to sepsis. Then there is in pregnancy, what we call chorioamnionitis, inflammation of that is infection to the chorion or the amnion. Then there is urinary tract infection. This could be in pregnancy or post-pregnancy. Then there is mastitis or breast abscess, which could happen after delivery. Maybe the mother fails to breastfeed well, she gets cracks on her breast, which becomes an entry point of infectious organisms. Next. What is the management? The number one management is you recognize. You recognize there is an infection. And how do you recognize that there is an infection? This mother might present with tachycardia. She might present with fevers. And one thing that I've realized in practice, a mother might also present with hypothermia, which is becomes a little bit tricky for you to determine if there is an infection. Then the blood pressures will be low. This mother will come with high fevers that are not going down. Those are some of the things. The pulse rate will be low. Those are some of the things that will tell you that there is an infection. Immediate action, that is the first hour, which is usually referred to as the golden hour, because this is the hour that will determine if you really save the life of this mother. It is the assessment of the ABC, then IV access and fringe, then give broad spectrum antibiotics. For the antibiotics in the management of maternal sepsis, you really don't have to wait for the lab results before you give the antibiotics. You begin with the antibiotics, then the lab results comes later. You can change management after, but you commence the treatment before, even without the lab results, because in some of our settings, you might even find the lab is not functional. Then you identify and control the source of the infection. Then you monitor closely, referral. Then baseline, you do community health education to mothers. You tell them signs that they might see even after delivery that might make them to come back to the facility. Next. What are some of the challenges in our rural settings? Some of the challenges in our rural settings that usually contribute to high maternal mortality rates. Number one is limited blood bank services. In our rural settings, I think except in our referral facility in the county, that is the only place where we have a blood bank. So that is one of the contributing factors. Then inadequate theater facilities, like in our sub-county, we don't have any active theater. That is for the government facilities, but we have one for the private. That is a faith-based facility. We have one that has got a theater facility. Poor ambulance services. Also, the ambulances for referral services are not enough. In a sub-county, you might find only one ambulance that is available for all the facilities, like one ambulance serving like 5 facilities. Then we have delayed decision-making. This begins from the communities. The mother takes time before she comes to the facility. And we also have the cultural barriers. For example, those that are in obstructed labor, there are some cultures that discourage delivery through cesarean sections. And so they prefer better the mother strains and gets an FSB other than going for a CS. Next slide. Key strategies to reduce maternal mortality. Number one is early recognition. Number two is AMSTIL, that is the active management of that stage of labor. Then we have emergency preparedness, having fluids in our facilities, having magnesium sulfate, calcium gluconate, then team training by continuous medical education, and then community education. Like I think it is yesterday that I had a mother who came in with PPH. She had a home delivery. Why? Because this mother didn't have this medical cover that we are having for our country right now, the SHA, and this mother didn't have the money to come to the facility, to come and pay for delivery at the facility. But later on, she ended up coming to the facility with PPH because of retained placenta and perennial tears. So these are the things that are contributing to maternal mortality in Kenya. Next slide. Referral principles, the delay model. like Roshi talked about it, it is delay in decision-making. This is from the community. A delay in reaching facility, that is a means of transport. The roads, some roads are not passable. Then when it comes to the facility, maybe delay in receiving care. Yes, some mother might come, but she might delay in receiving care at the facility level. In our case, we are trying in Kenya, in our rural settings in Kenya, we are trying at least to tackle all the delays, because like delay in a decision to seek care. Currently in Kenya, we are having this we call CHP, the community health promoters, whom we are using to educate mothers in the communities on importance of ANC and having safe delivery with a skilled attendant at the facility level. Then for the delay in reaching facility, that is a bit tricky because most of our roads in Kenya are impassable, and also the means of transport, like I've said, the ambulances are not enough to go reach to the mothers and bring them to the facility. Delay in receiving care, we are trying, though we also have shortages of staffs in our facilities. So you might find one staff is overwhelmed in the maternity department, but we're also trying to curb maternal deaths by these. Yes. Conclusion. Most maternal deaths are preventable, and this is achievable by early detection and prompt resuscitation, then timely referral, and continuous medical educations to the service providers. Thank you. Hope we learned. That is all from Joy. Any question is welcome. Thank you.
Thank you so much, Joy. That was super interesting and I think really complimentary to Roshni's presentation. Welcome again, any questions? I guess my pressing question that I was hoping to ask, if you don't mind, to kickstart was regarding, you talked a lot about referrals, and I was wondering how I know quite often the family or end up being the transport to care. Is that something that you because in the UK we probably wouldn't, we're very cautious in that transfer process because we know it's so dangerous. How often is that something that the family are taking responsibility for because of the delays with ambulances?
I beg your pardon, I've not gotten you, Mandy.
Sorry. How often is it that you're relying on the family to transport the patient when if your facility is unable to provide the complete care that you feel they need?
Okay, for the transportation of patients from the community to the facility, it is the responsibility of the family to know how the patient will get to our facility. Our responsibility gets in when this patient comes to our rural facility and referral to the main hospitals. From the communities to our hospitals, that is the responsibility of the family.
But if you then want to send them on to another facility, is it common that the ambulance is too long and you ask the family again to transport that patient, or will you always wait for the ambulance?
No, we don't wait for ambulances, but in cases of emergency, we waive patients for referral from one facility to the other facility. But on normal deliveries, we don't waive them. Unless when there is an emergency, that is when they get a waiver.
Okay, thank you.
Then, welcome.
Any other questions? Welcome. although. Oh, someone's raised their hand. Feel free to jump in.
Yeah, my name is Nantaga. Background in emergency nursing, experience in Ghana and in the UK. But just wanted to contribute with the last question which you asked. I think haven't been to Kenya, but I think challenges are shared. Kind of health challenges are kind of similar in Ghana. And when I was in Ghana, we used a mixed approach. So fortunately for the very rural place that I worked, we had a telemedicine center where we basically will sometimes have to charge on the phone as to what severity is that mother currently in. Is it a case that we could transfer by let's say a taxi, which would be faster, because technically speaking, it was going to take me 4 hours to get a patient to me. That is probably 2 hours to get the ambulance to where they are picking the patient, and 2 hours to get a patient to me. A taxi will probably get them to me in less than an hour. So sometimes it's about knowing the context. It's about knowing your locality. It's about being able to tried whilst not being there. And I think Joy did mention community workers, and they were one of the very important skill set that we had on that program, that you would usually try to get the closest community healthcare practitioner to get to the house and at least give you a bit of a healthcare related assessment, say that, okay, this is what I see, this is what I see, for you to make that decision. So I think it's always a mixed approach. If the ambulance can be there to get a patient to you, fine. If the family have to get a taxi to get a person there, fine. Is it safe to sometimes carry them on a motorbike? And this is just first-hand experience I'm sharing. I've seen pregnant women being carried on the back of a motorbike, because that's the most fastest way to get them to you, either than waiting for a taxi that cannot probably even go to where you need them to pick them from. You sometimes end up using all three means. So a motorbike gets them to a certain point, a taxi gets them to a certain point, and an ambulance picks them because the ambulance cannot go further. So I think it's always, and most of the time, situational as to where you find yourself and what resources that you have available, but always making do with the most safest and fastest way to get that pregnant woman to definitive care is always what we aim at.
Yeah, 100%. And as you say, getting someone who might be able to assess them. Would you ask that person to then travel with them if possible, or not, if that's going to be
Yes,
a time
occasionally, yes, occasionally they did travel with them, but you were not always going to get them to travel with them. So if this very severe, let's say that if the person is severely bleeding, and let's say they are like 2 hours to me for definitive care, the next thing is to try to estimate the closest clinic that they could get them to. And you are always usually very sure of getting either like a midwife or like a healthcare staff in that clinic, manning that clinic, where you then will probably do some kind of abridged management to then get a person to definitive care, where you be taking most of those critical decisions. But yeah, it's just always continuously assessing the situation and seeing what is better, getting them straight, getting them to somewhere closer, and then getting them to you. And we've conducted some deliveries over the phone, because that was the only way. It's just to support them out there to get a child out and then get a child and the mother over to you for assessment and continuous treatment.
That sounds like an amazing, amazing facility that you've got, and something that I'm sure many rural facilities would be very envious of. Okay, if anyone does have any more questions for Joy or Roshni, feel free to message them or me and I can pass them on. Thank you so much for attending. I've posted the feedback link in the group chat, and it would be amazing if you could give us your thoughts, and that will also generate a certificate for your records. Always keen to hear from anyone who has any topics that they'd particularly like to have some teaching on, and anyone who's particularly keen to present, we would love to hear from. Okay, thank you so much. Have a lovely evening, everyone, and we'll see you next month. And the topics and everything will be advertised in due course. Okay, thank you.